choosing the catheter, choosing the amount of tension, counseling patients properly is a key. We do the procedure, and speed. I think the first thing is you want to get that catheter. You've created the crack, and so we're supposed to blow the first balloon up for a minute. Well, bleeding time's a lot more than a minute. So technically I'll tend to leave the balloon a little bit longer with the idea that if I pinch my nose for a bloody nose, if you hold it a bit longer, it seems to do a good job. So the next balloon, 10 minutes, and then once that's deflated, I put my three-way catheter. So I want a three-way with a larger balloon, and I'll apply some gentle venous-like pressure with a wet noose at the end of the catheter. So you're kind of coordinating the balloon against the penis so that, well, if it's gonna bleed along that crack, well, the balloon prevents that blood from going in the bladder to get the clots, and it's the clots in the bladder, that's what gets us into trouble. And if there's anything, that bleeding within the urethral chamber is tamponaded by the noose, of the wet noose at the outside of the penis. And that's it. So really, are we dealing with arterial bleeds? No, we're dealing with capillary, maybe venous. And if we think about our basic principles of pressure within venous, we're looking at maybe 5 or 10 millimeters of mercury pressure. So long as a patient didn't forget to tell you he's on a Coumadin or a direct anticoagulation medical therapy, I really think that bleeding is no different than a bloody nose. We've all seen some flash blood. We think we may call 911, and somehow 5 minutes later with some pressure, we're okay. So in cases, let's say 30 minutes all in from the time of initiation to the end of the procedure for the Optilume, then for the next 30 minutes, the patient will go to our little hold step-down bed in our secondary procedure room, and we'll run a second 1-liter bag of CBI with traction, make sure they're okay, and they're discharged home thereafter on a leg bag, no CBI. Touch wood, we've not seen a transfusion. If you look at all the Everest trials, people worry about bleeding, but how many patients have been transfused? None. So sure, we worry about bleeding, but who's really worried about the bleeding? The physician who's getting called at 1 in the morning because there's a clot retention. That's the kind of stuff that you're gonna deal with, but if you manage them well, you do them in the morning, you hydrate the patient well, you counsel them well, that kind of stuff is, I think, just regular urology. So I'm not phased. I would not think that this is as cumbersome. I'd be more worried about like aquablation or these other types of ablative maximal therapy. Then we got about bleeding, but again, technology, we took those kind of bleeding rates from 5% transfusion down to 0.4. So if you know what you're dealing with, you understand anatomy, you know what you're doing, plan ahead, and the 5 Ps, planning, preparation, prevent poor performance is the kind of adage that I've used for my practice and seems to work for this as well.